We're moving on now to taking a look at one of the organizations that's doing a lot to support coaches from an outside perspective or from a parallel organization perspective, the American Medical Society of Sports Medicine. And we're lucky enough here in Morgantown to actually have a member of that organization that's here to represent today, who's also known as the team doc, works a lot with the teams and does a lot there within the WVU system, Dr. A.J. Monseau, who's going to be talking a little bit about how the AMSSM, I always put the S's in the wrong place, is working to try to support this idea of better coach development and better coaching for better athlete experiences.
All right. Thank you all for having me. I have no financial disclosures. I will disclose, though, that I feel like I'm behind enemy lines here, not because of you guys, but as the College of Law, we always joked in medical school that we view this as very much behind enemy lines. I did spend several weeks studying for one of my board exams in medical school in the law library just to escape the distractions of my classmates. So I did spend some time in this building, although relatively little. My role here, as Kristen said, as a representative of the American Medical Society for Sports Medicine, just my attachment with that society there, and now to add a new one, I guess, as a representative here. My perspective, though, on, I'm fascinated by the things that have already been presented here. My role here at WVU, I'm the head team physician. I'm also the medical director for intercollegiate athletics. I'm an emergency physician by training. I still work shifts at our Level 1 Trauma Center, which is just across the parking lot here. I'm faculty at the medical school, and now I'm the fellowship director for our Primary Care Sports Medicine Fellowship, which we've just been able to start this year. So we're very excited about those things. My other perspective, though, comes from outside of medicine. So I was also part of the USA Wrestling contingent as the team physician at the Rio Olympics. But I'm the son of a coach, not just somebody who dabbled as a volunteer coach, as we've alluded to, is the vast majority, I believe, of kind of what we're alluding to here today. But 52 years in education, a college and high school coach, got his EDD from right here at WVU, psychology and sociology of sports. So I grew up with this. I grew up with this kind of attitude toward a greater sense of the purpose of sports and the purpose of a coach, and I feel that was invaluable. I would say my other perspective, though, is through my own children, and that's being a volunteer coach and having to do no less than, I think it was 3 or 4 different of the online trainings to be a coach for baseball and softball and soccer and football and some wrestling now. So I've been touched by several of these things. We look at medicine and the coaching side of things, and all too often they're very separate, right? And what we need to do is bridge the gap, and I put our New River Gorge Bridge here from West Virginia. Bridging the gap can be very simple things, right? So it's injury patterns of specific sports, whether it's overuse things or just traumatic things that we note are on an uptick or are just prevalent in certain sports. But then also the prevention strategies to prevent those and treatment strategies, and trying to get our coaching staffs who have so much one-on-one time with our athletes to buy into some of these things, whether it's prevention things or treatment. Even down to practice plans, right? Because we know there are some practice plans that are just not realistic, number one, likely inducing overuse injuries, number two, and we want to make sure that we're doing our very best for our athletes. And then finally, our emergency action plans. And as part of my position with my background in emergency medicine, before doing sports medicine, we know that a good emergency action plan is something that is imperative for all of our athletic facilities. Here at WVU, we utilize 35 with our new swimming complex. 35 facilities around town are utilized by our 16 sports. So we are often in variable locations and trying to make sure that we're prepared for anything that could happen at all those. AMSSM nationally has had several initiatives. First of those being or most recent of those being the Youth Early Sports Specialization Summit. Talk about getting too many S's into an acronym. This is the one that did it. So in Houston in April, and Kristen was on a panel there for us. And yeah, the notion of the young athlete who is being pushed to subspecialize way too soon, and I know I'm likely preaching to the choir here, but we know it goes on all too often. And there's been a big social media push from AMSSM, from other organizations, and we know that for years, good coaches are going to push their athletes to cross-train because they notice these overuse things, and they notice that other sports or other activities will improve other parts of an athlete, whether it be in their social skills, number one, or if it's in their actual physical skills, whether it's some gymnastics or tumbling or grappling or wrestling type things for balance, or whether it's more team sports to, again, improve how they interact with other people. The AMSSM has really pushed this now just to try to look at the athlete as a whole, and especially the young athlete, to try to prevent injuries. Another thing that is being worked on through our organization is the physician toolkit, which is meant for parents and coaches and athletes, and we are hoping to have that done in the spring of next year. And this would be, if you think of the online resource from the CDC for concussion, which has different tools for both coaches and athletes and parents, as well as physicians. This would be something similar to that we were trying to tailor to individual sports. And just getting data out there. We know parents, especially coaches as well, are often searching the internet, trying to find data on different injury patterns or exercises to prevent those, and what can we do to give some training recommendations. Just recently, the NCAA, obviously initiative with the Preventing Catastrophic Injury and Death, has pushed our EAPs to address these areas. So we went back through this year, as many institutions did, and redid our EAPs to address those. And that also meant sitting down with our coaches, specifically our strength and conditioning coaches, who have the highest risk time period with our athletes. We know that, just looking at those folks who have had bad outcomes, that the highest risk time period are our strength and conditioning workouts, especially during transition times. And so finding practice plans that are evidence-based, consensus-based, sport-specific, intentionally administered, appropriately monitored, and not punitive in nature, which we all know can be difficult at times. So, from the medical side, we have attempted to, bridge this gap, and we really want more of a bridge, right? We want more than a bridge. We want a collaboration, and we want to move that even further so that the knowledge that's gained on the medical side, as far as injuries, injury prevention, practice strategies, whatever it is, can be implemented into our coaching education as well. Here at WVU, in addition to redoing the EAPs, we also got our heat protocol finished this year, and that we were able to give some kind of finite numbers. Many of our, when looking around the country, many of those heat protocols have very general recommendations for coaches. We tried to get as specific as we could, just to make sure that we're not just kind of setting up some kind of piece of paper that really has no real information in it. And the other thing with the EAPs is that we've looked separately through some of our own research at EMS protocols throughout the United States. So if you think of the 50 states plus Washington, D.C., so 51. We took a representative EMS protocol from each one of those states. About 2/3 or so have actual statewide protocols, and the rest we used city and regional. And in those, only 10 allowed for the proper treatment of exertional heat stroke. And so even if a coach, an athletic trainer, a physician steps in on the scene and puts somebody in an ice water tank to treat exertional heat stroke, which is the appropriate treatment, if an EMS crew shows up and it's not permitted in their protocol, they now have to call in to their medical command. And so we provide medical command in West Virginia. There are 55 counties. We provide medical command for a little over 35 of those counties, I believe, is the most recent count. And so they call into us, they tell us what the situation is, and now you're left to a human to make that answer and to make that decision. And we know when you introduce humans into it, we make mistakes. So trying to change, kind of the national attitude toward heat stroke, specifically exertional heat stroke, and the proper treatment for that, which is a kind of an overlap area there between coaching and medicine. And finally, I again thank you all for having me here today. It feels, obviously a little bit of the outsider, as Kristen, when I walked in, said I was the only one she didn't really know in the room, which is interesting because I'm from Morgantown. But we all have the same goal, right? And that's athlete wellness and well-being, creating a safe atmosphere for sports, obviously in your local communities and nationally. And I commend you for all the work you all are doing.